So now let us just hop over to the next phase of understanding National AIDS Control Program. In this video section, we are going to talk about some other strategies, organization of National AIDS Control Program, and the monitoring evaluation indicators. In the previous module, we have already talked about the targets 90-90-90 and all that. We talked about the diagnostic modalities, management guidelines, prophylaxis of HIV infections and other infections, which is a very 5-star MCQ topic for your exam. Then you have prevention of mother to child transmission, which of course is overlapping with pediatrics as well. So now let's move forward and talk about some other strategies which are available under the NACO program. First is, what do we mean by the ICTC centers? ICTC centers stand for the Integrated Counseling and Testing Center. What is the use? They do counseling and testing both at the first place. How many types of ICTC centers do we know? We know 2 types of ICTC centers. Either the center could be in a position, it's not moving, or the ICTC center will move, that is a mobile ICTC center. If it is in position, that means it could be a standalone ICTC center or a facility integrated. These are called as the SAICTC centers, or we have the FICTC centers. What is the difference? It is very simple to understand. Let us say that there is very huge caseload of HIV in the area, or there are some hotspots, some commercial sex workers are there, truck drivers or migrant labor is there, or something, some hotspot is there. So in case there is hotspot, of course, there will be more cases of HIV. If there is more cases of HIV, we will have a standalone. It's a alone ICTC center. So that happens in district level and above centers. And it is for large population. It is for larger population. Whereas the facility integrated ICTC centers will be where the low caseload is there. If the caseload is very low, you will have the facility integrated ICTC centers. Question number 6. What do we mean by the HIV sentinel surveillance? See, I hope you understand that commercial sex worker is there, which is the one of the highest group of HIV. Now, one commercial sex worker, if he or she, that could be a male or a female, if that commercial sex worker is infected with HIV, that person, he or she will infect other 4. Then there will be the clients who are infected now. Now the client, let us say, will infect other 4 commercial sex worker. Are we able to get it? So where is HIV high risk? The high risk HIV is happening in the commercial and commercial. But who is spreading the high risk? Who is spreading the commercial to commercial? Is the commercial sex worker spreading from one to another? Answer is no. So who is spreading? It is the clients which are spreading. It is these clients which will be spreading it. They could be the male migrants, these clients, or in just gross words, I'm saying clients. Actually, the technical word is called as, this is the bridge population. They form the bridge between the 2 high-risk groups. Are we able to get it? So the bridge population has to be very importantly screened for HIV. So that type of surveillance that we do of finding the missing cases. So that's what you need to remember, beta. The surveillance activity to find the missing cases, missing cases. Please highlight in your copies, find the missing cases. This phenomena is called as sentinel surveillance. This is called as sentinel surveillance. Okay, so please note that what do you mean by sentinel surveillance? It is to find the missing cases. Who is the missing cases? The bridge population will be the missing cases. They will tell you that, like, the sentinel surveillance is going to tell us what is the exact load of HIV in the community. Based on the understanding of the sentinel surveillance, let me move forward and talk about what do we mean by the serosurveillance. Topic number 7. What do you mean by serosurveillance? See, what happens in the whole country is that we actually do not know how many people have HIV. I told you this problem before also. So how to find out what is the real burden of HIV? So what we do is we try to find HIV in some people. So we take a sample of population, and in that sample we are going to find HIV. Whatever is the HIV in that sample, that will be extrapolated to the whole country. There is a high level sampling methodology which is attached in serosurveillance. The last serosurveillance was done at a country level in year 2016-17. The reports are available with us. So what they did in 2016-17 for finding the real burden of, or understanding the real burden of HIV, is they divided the whole country, like the sample site, one sample site, into 3 groups. So they will be checking in the high risk groups, the bridge groups, and the general population. So they will check the HIV prevalence in the high risk groups, in the bridge population, and in the general population. So in general population, we cannot knock anybody's door and say that I want to test your HIV. It's not done. So what we do is we always take an informed consent from the patient. Informed and consent has to be taken, and we do the general population is taken as the proxy is taken as the ANC females. So we will take some number of the ANC females. In them, we will try to find out what is the level of HIV. For the bridge population, we take 2 groups. The first group we take is the single male migrants. The second group we will take up is the long distance truck drivers. So these are the 2 groups we take in the bridge population. This can be your MCQ. This is one of a high yield 3-star MCQ point for you. Next is, what are the high risk groups? I think everybody knows about the high risk groups. What are the high risk groups? The high risk groups are commercial sex workers or the female sex workers. Second would be male having sex with male, male to male. Third will be intravenous drug abusers. And fourth is the Hijra group or the transgender. Hijra or the transgender. So what are the 3 groups? Beta, please say with me. So we have divided this whole serosurveillance. The sampling units will be divided into 3 groups. What are the 3 groups? Say with me. It is, we are going to talk about the high risk groups, the bridge population, and the general. Who is the proxy indicator of the general? That is the ANC. Who is taken in the bridge population? We take the single male migrants and the truck drivers. And in high risk groups, we take the 4. That is the commercial sex worker, male having sex with male, intravenous drug abusers, and Hijra transgender. So just to show you these groups, please note that we have talked about the female sex workers, male having sex with male, injectable drug abusers, transgender, H and TG. H and TG stands for the Hijra and the transgender population. Then we have the single male migrants, the long distance truckers. This is your favorite examiner MCQ. General population is the pregnant female. So what we do in this serosurveillance? This serosurveillance is done for a duration of 3 months. It has to be done. It is done every 2 yearly. The age group we take is 15 to 49 years. The testing strategy, the system that we adopt is very important for your exam. This is called as unlinked anonymous testing. It is called as unlinked anonymous testing, and the testing protocol that we adopt is, this can be asked in your exam again, that what is the testing protocol? It is the minimum 2 test protocol. It is a 2 test protocol. So please note that a lot of questions come on HIV serosurveillance. So what are the groups? This is important for your exam, and you should also know that what are the sampling methodology that we use. Another MCQ would be regarding the sample, would be like, how much is the sample size? Sample size. Please note that the sample size for the high risk groups and the bridge groups, it is taken as 250 population in that particular group, and then for the ANC it is taken as 400 population. So how much population? 250 for each. So 250 will make 500 plus 400. 900 people are taken in one sample site, and there are many sampling clusters like these, and then whatever is the prevalence, that is taken as the national understanding. So just to show you that how this program had been conducted, there is a protocol guideline book called as Sankalp. So this actually tells us about the prevalence of HIV. Just to show you a little bit more about the statistics from the HIV serosurveillance conducted in year 2016-17, the ANC prevalence was found to be 0.28. But the problem is not about this ANC. The problem is about this intravenous drug abusers. Can you believe that the intravenous drug abusers, the HIV prevalence in intravenous drug abusers is 6%, which is pretty high. And that is what is the problem, that this cluster is highly transmitting. The intravenous drug abuser cluster is highly transmitting. The ANC, please note MCQ can also be asked on this, that the ANC, this is taken as the proxy indicator. The ANC is taken as the proxy indicator for general population. For general population, the ANC is taken as the proxy indicator. Next point number 8. Let us talk about the HIV-TB coordination. What do you mean by HIV and TB coordination? Please note that it is so strongly associated that any case of HIV is bound to be at risk of getting TB, and any case of TB may get HIV anytime. So there is a very strong association between HIV and tuberculosis. There are a lot of questions on this. First MCQ for you to understand is that, is there a testing methodology? I think we discussed this in tuberculosis. Can you please go back to the TB module in case you have forgotten that? That is ultra important as point. Please note that in all cases of HIV, we will test for TB, and TB we check for HIV. What is this called as? Bidirectional. This is called as bidirectional testing. All cases of HIV will be tested for TB, and TB will be tested for HIV. Point number 2. In all cases of HIV, we already discussed this in TB. In all cases of HIV, we are going to give the IPT prophylaxis. We discussed this in the previous module also. IPT stands for beta, isoniazid preventive treatment. So it stands for isoniazid preventive treatment. Next, point number 3, in all cases of HIV and TB, what are you going to start first? Please note that are you going to start the ART, that is the antiretroviral therapy, or are we going to start the anti-tubercular therapy? Please note that we always start with anti-tubercular therapy. There are two understandings, there's two school of thoughts over here, that if this is a patient who's got HIV and TB, we always should start with the TB treatment. Why? Because the TB is airborne route of transmission. So the transmissibility or the communicability of HIV is like restricted because it's not airborne, but TB can be airborne. So we start with ATT first. But the real biological reason for starting ATT is that there is something called as the SIRS, severe immune reconstitution syndrome. So there is a chance that in case we do not start the TB treatment, in case we are starting with the ART, that is going to increase the immune status, that is going to increase the CD4 count. If the immune status increases, there might be hyper reactions, or there might be more flare up of the TB bacilli, because TB bacilli is showing a hypersensitivity reaction. That is what is cavitation, that is what is tuberculosis. So we are very kind of scared with this SIRS, and that is one of the reason that always means hamesha means every time. So we always start with anti-tubercular therapy in a case of HIV and tuberculosis. Don't make this mistake. Another point which can be asked in your exam is better that whenever we are giving this anti-tubercular therapy, in that if you are giving rifampicin based regime, rifampicin is given. In those cases where you are giving rifampicin is substituted. It is substituted with rifabutin because of the drug interaction. So we always start with anti-tubercular therapy rather than the ATT. Another point which can be asked in your exam is for HIV-TB, we're still on the HIV-TB coordination, is that in all cases of HIV, how are you going to find tuberculosis? So what is the first line investigation of choice? Please note that the first line investigation of choice will depend on the HIV. Let us say that this person has HIV. Now I'm going to find TB in that. So in case we are finding TB, can we find the cavitation? Please note that what is cavitation? It is a hypersensitivity response. So please note that in case of HIV, ICO stands for in case of. In case of HIV positive persons, in those cases there is less chance of cavitations. Why? Because the immune status is already low. There is also less chance of sputum positivity. So the sputum negativity is pretty high. So now because there is less chance of cavitation, there is less chance of sputum positivity, the first line of investigation in all people living with HIV, in all children living with HIV, in all the high-risk cases, we do I think we have discussed it a lot of times. CB NAT is the first line investigation of choice in all these cases. Next is about the immunization. One of your frequently asked doubts. I get this doubt almost daily. It's like every day I will get the doubt that do we give vaccines to HIV positive bacha? Please note that in case the child is HIV positive. What do you mean by HIV positive? This is a immunodeficient state. Immunodeficient state. In case the child already has immunodeficiency, if you don't on earth give the vaccine, the child is invariably going to land up with measles. Do you think you should give vaccines? Common sense here, you should give vaccines. Please note that all vaccines are given as per schedule. Please copy this. Please write it in your brain. It is given as per schedule to the child, except few exceptions. Except, please note, mark it, except. All vaccines are given. What do you mean by all vaccines? Killed vaccine, recombinant vaccine, live vaccine, toxoid vaccine, every vaccine. Except which vaccines? Please note, except which vaccines or in which situations. Except if the CD4 count is less than 15%. This is the relative CD4 count is less than 15%. If the absolute CD4 count is less than 200 cells, or if the child is in stage 3 or stage 4 or any symptom of HIV, we are not going to give. Please note, we are not going to give. Avoid the live vaccine. Avoid live vaccine. I hope I'm very clear on this. Please note that all vaccines will be given except the live vaccines in case the child is severe immunodeficiency. This is what we call as the severe immunodeficiency. Severe immunodeficiency. A special requirement over here is that sometimes examiner may trouble you. Now, the examiners are fed up by asking you every time that live vaccine do you give in HIV, yes or no. Answer is everybody knows it now that it is given except in severe immunodeficiency. Now the examiner is very clever. They will ask you about the rabies vaccine. About the rabies vaccine in HIV. Now the patient is having HIV. Unfortunately, there is a dog bite and a category 3 or a class 2 bite. So please note that in cases of dog bites or animal bites, in case of, ICO stands for in case of animal bites, in case of animal bites to a HIV positive person, please note that we always advise intramuscular injection rather than intradermal injection. So intramuscular injections are recommended, point number 1. Second point is you always will try to give rabies immunoglobulin, especially the human rabies immunoglobulin. The human rabies immunoglobulin is advised in both class 2 and class 3 bites. For details on this, please watch the rabies video section. But over here, I just want to appraise you that for rabies vaccine also it is kind of complexity for HIV and rabies. So the human rabies immunoglobulin is given to both class 2 and class 3 bites. Normally it is given only to class 3. Rabies vaccine in HIV is supposed to be given. And the next one is your 5-star MCQ topic, 5 by 5-star MCQ topic. What do you mean by the Suraksha clinics? It's a slightly point of concept to understand that why NACO started the Suraksha clinics. But in the Suraksha clinics, just a brief to introduce you. Suraksha clinics will do what? They will help you in treating the RTI STIs. So in the Suraksha clinics, we are giving free of cost treatment. There is a free treatment which is available to the RTI STI. Why do you think the NACO people, they started Suraksha clinics? If NACO people start doing RTI STI treatment, what will the venerologist or the venerology department do? It's not about impinging into anybody's department. See, try to understand. Let us just go back and talk about what do we mean by the sentinel surveillance. Do you remember that? What do you mean by sentinel? Sentinel means any person who is a watch guard. That is actual English meaning of the word sentinel. So a sentinel is a person who will open the main door for you when you enter a big 5-star restaurant. So what government wanted was to find to do sentinel surveillance. That means to find what? To find the bridge population or the missing cases, or to find the clients or something like this. You already know that these are called as the high risk groups. That is the bridge population, that is the single male migrants, the truck drivers who will be exposed to the high risk groups. That is what we mean by this. So now to find the bridge population, what is the method? How will you find the clients everywhere? How are you going to find the single male migrants? We cannot do contact tracing. You cannot ask anyone that what is the address or anything like that. So what we can do is we can have something in common. What is there which is common in all the clients? The problem is that most of the clients who are having unprotected intercourse, they will sometime or the other will develop some RTI STI. Am I correct? So now, because if they develop the RTI STI, don't you think that these people will be going to some of the infectious disease clinic? So that's what NACO thought, that let us say this is the area, we will establish the infectious disease clinic. The clinic name will be called as the Suraksha Clinic. That is the Suraksha Clinic. Okay. So in that clinic, we will give free RTI STI. So what is going to happen? The clients will be coming here. If the clients or the bridge population will come here, they will get treated with RTI. Plus, we also build a base that these are the people who might be spreading. So you do HIV awareness, you do condom promotion, you do all your activities, and you try to change the behavior. The behavior of the clients is actually changed. So for that reason, we do a Suraksha Clinic, and in Suraksha Clinic, what is the treatment we give? That is what your MCQ beta comes in your exam. The treatment that we give in Suraksha Clinic is called as syndromic management. Syndromic management. So now that is what is your question, that why do we give syndromic management? It is not to treat anyone. It is actually to build the base so that you are actually preventing RTI, STI, and you are trying to promote HIV awareness where among the bridge population. Are we getting it? Because if you are trying to do all the condom promotion, everything in the commercial sex workers, still the bridge population is lying vacant. So that is what we do in Suraksha clinics. MCQ over here, what do you mean by syndromic kits? How many kits you see over here? You see 7 kits. You see 7 kits. So beta, what in your exam, you will have to remember the name of the 7 kits, the number, and you will have to remember the color of these 7 kits. So please note that you can remember that there are 7 kits we have. So the first kit is a gray color kit. You can just remember it as a good girl with blue, red, yellow bag is going somewhere. That's how I have remembered. I don't know, it's such a boring community mnemonic, but that's how it is. So you can remember it as a good girl with blue, red, yellow. I don't know, that's a bad one. Bag is going. So how I have remembered is a gray, green, white, blue, red, yellow, and a black color. So these are the colors for the kits. In kit 1, that is for any cervical discharge, any cervical discharge or any urethritis is kit 1. Very easy. I'll just try to make the thing simplified for you. Just look at the screen and try to follow what I am saying. So the kit 1 is for any urethral discharge, any cervical, in fact, any discharge. But specifically for a vaginal discharge, for vaginosis, for vaginal discharge, for bacterial vaginosis, we give the green color kit. Next one is this kit number 3, 4, and 5. Now this kit 3, 4, 5, that is very interesting. You can discuss everything all together. So I have just remembered that these kit 3, 4, 5, they are usually for genital ulcers in general. So I have remembered that kit 5, somehow I have remembered that 5 is for virus. So which is the virus which causes the genital ulcers? Answer is a herpes virus. So for kit 5, it is for herpetic genital ulcers. Herpetic genital ulcers. So in case it is a viral ulcer or a herpetic genital ulcer, what is the drug that we are going to give? You're not going to give any other antibiotic. You are going to give simple acyclovir. So that solves our problem for the kit 5. Now because 3, 4, 5, they all are genital ulcers. If 5 is viral, so of course kit 3 and 4, they are bacterial. So what is kit 3? Very simple to understand now. Kit 3 is for a bacterial genital ulcer. If it is for bacterial genital ulcer, what is the drug of choice you would like to give in this kit 3? The bacterial genital ulcers, we are going to give, what is the best drug we are going to give? That is the benzathine, penicillin. You give penicillin, which is the most potent antimicrobial that we have. Plus, along with penicillin, we also give them azithromycin, right? But now you're giving penicillin to kit number 3. Don't you think that some patients might be penicillin allergic? So that means kit number 4 you should have for patients who are allergic to penicillin but with bacterial genital ulcers and allergic to penicillin, or they are penicillin sensitive. So now to them you cannot give penicillin, so you should give them something else. What is the something else? You give them doxy. So to them we are now going to give doxy plus azithro. So that solves most of your confusion from kit number 3, 4, 5. Next, if we look at it as the yellow color kit, somehow I have remembered that yellow is for PID, pelvic inflammatory disease. So there are 3 alphabets in PID. So what is the drug? There are 3 drugs. I know these are silly ways to remember, but that's how I have remembered. And the 3 drugs that we are giving is DMC. In PID, we give DMC, that is doxycycline. Plus, we give metronidazole, and we give cefixime. So these are the 3 drugs that we give in the pelvic inflammatory disease in the yellow category, in the yellow color kit, that is the kit number 6. In the kit 7, that is a black color kit, which is for inguinal buboes, and the drug that we give for inguinal bubo, that is azithromycin plus doxycycline, that is the same as kit number 4. So we give azithromycin plus doxycycline, that is as the kit number 4. Now we are left with simple one, that is the kit 1 and kit number 2. Kit number 1, we give cefixime plus azithromycin. If you want, you can remember. You should actually remember the kit number 1. You should remember the kit number 5. You should remember the kit number 3. And you should remember the kit number 6. That is kind of important. The kit number 2 that we give is, if you want, you can remember, we give 1 single tablet of fluconazole and secnidazole in cases of bacterial vaginosis, that is the green color kit. So we are giving a green color. So I have remembered it Flora, and that is green color. Fluconazole plus secnidazole in the second category, in the second kit. So these are your kits, and it's easy, kind of easy to remember. So just note that these are the things you would like to remember. Kit number 1 is for cervical discharge. Kit number 2 is for vaginal discharge. Kit number 3 is for bacterial genital ulcers. Kit number 4 is for patients who are allergic to penicillin and have the bacterial genital ulcers. Kit number 5 is for viral, that is herpetic genital ulcers. Kit number 6 is for pelvic inflammatory disease, and kit number 7 is for inguinal buboes. So these are a couple of things you would like to remember. This is what is the Suraksha Clinics. A lot of times they have asked you MCQs on Suraksha Clinics, syndromic management. Many times they come in your exam. So now moving on to the last part of the strategies. What are the other strategies? The other strategies, nothing very special. There is condom promotion in NACO program. Please note that under the NACO program, they are giving Nirodh condoms. They are also giving free of cost the deluxe Nirodh condoms. To the females, to especially talking about the female sex workers, it is also given the FC2 condoms, that is the female condoms. The female condoms which are of good quality, that is either they could be the latex or the polyurethane. Now they have started using both. So latex condoms are also being used. Latex female condoms are also being used by the NACO program. Another MCQ over here is, what about the safe blood practices? I would like to spend one point over here, that what do you mean by the safe blood practices? Please note that you must have given blood donation. You must have donated blood sometime. Have you ever attended a blood donation? If you would have attended, then there is a page which you have to sign And on that page, they say that I want to know about my HIV status. Try understanding that the NACO guys, they are not asking you that can I do HIV testing in your blood, yes or no. They are asking you that we are going to do HIV testing in your blood. Do you want to know about your HIV status? So it's such a different phenomena over here. Please note that the concept behind this is that what do you mean by blood donation? Donation is something you have donated. Now, donation is if I have donated blood, that blood does not belong to me because I have donated it. So I can't ask it that you give back my blood. So now that blood is the property of the person who took that blood, right? The blood transfusion department. So they will test the HIV in them. Why? To find HIV in the donor or to save the recipient. You say, please note that the safe blood practices is to save the recipient from HIV. What level of prevention is it? Safe blood practices is a primary level of prevention. You remember what was the primary level? It is to prevent the disease. So you are trying to find the disease in the donor or to prevent the disease in the recipient. You are preventing a disease in the recipient. So that is what is a primary level of prevention. Another MCQ which can be asked on the safe blood practices is like, what is the methodology of testing, or what is the method or the tool of the screening? The tool of screening or the screening method which is used in blood donations. See, that blood donation wala did not ask you, can I do HIV testing? They asked you, I'm going to do HIV testing. Do you want to know about your test? Answer result, yes or no. This phenomena, without your consent, they are doing HIV testing. That is called as unlinked anonymous testing. This is called as unlinked anonymous testing. In fact, you already learned about this word before also, where we talked about the HIV serosurveillance, where the whole methodology was based on the UAT testing. What do you mean by the UAT testing? That is the unlinked anonymous testing, and there's nothing very special. Only one point you should just understand. There's no MCQ on this. Only one point for you to understand is that it is unlinked. What do you mean by unlinked? That is the reports are not linked to that person, and it is anonymous. That's all. Anonymous means there is no name which is attached. So you will have a report, you will have a test, and the report of the test is not linked to the person who's donating the blood. That phenomena is called as unlinked anonymous testing. Just remember for your exam that UAT testing is used where it is used for blood donations. It is used for HIV serosurveillance. You need to remember this. Along with the UAT testing, you should also know that there is something called as the opt-out testing. What do you mean by the opt-out testing? Opt-out testing is better that you must have filled the Google form sometime in your life. Like some forms you must have filled in your computer when we log into some new website. So you fill a form that my name is this, and in the last there is a small line written that yes, I want to receive free updates or free emails or some brochures from you. So you go there and it was already checked. You go there and uncheck it. Why? Because you don't want spam in your mail. So by default, there is a testing methodology, and try to understand it now. By default, there is a testing methodology, and in the opt-out testing, all the ANC females will get by default the HIV testing until and unless the female says, no, I don't want this particular test. Are you getting it? So it's not something which the female will opt in that do you want. We are not asking the female, do you want this test, yes or no. We are just saying that this test, the default tests are already there. If you want to opt out, she can opt out. So as a basic package system that we give in the ANC care package, the HIV is already included. If the female she wants, she can opt out. That phenomena is called as opt-out testing. It is for checking for HIV in all ANC females. Please note, this is not the serosurveillance we are talking. As a ANC care package, we are testing for HIV using the opt-out testing technique. Otherwise, unlinked anonymous testing is used for surveillance anywhere, everywhere in the world. So that was for your safe blood practices, use of the unlinked anonymous testing, and you already remember that for ANC we use opt-out testing. Opt-out testing is used for ANC. Next MCQ, what is this Red Ribbon Express? It is a big train. It is a very beautiful train. I would say that we always love to go to the Red Ribbon Express whenever it is there in my city. And this Red Ribbon Express is going to promote HIV awareness. It promotes HIV and AIDS awareness across the country. It has a good amount of budget, and a lot of decorations are there, a lot of brochures, information, health education material is there. So the people do come to the Red Ribbon Express, and it travels across the country to spread HIV awareness. Next, what is this link worker scheme? See, the problem in HIV is that HIV is a social disease. It is a socially discriminated disease, and the problem is that it is in hidden groups. So now, because HIV is not freely available, you don't come across a street and a person says, "Oh, I was suffering from HIV." Nobody would do that. So this HIV, it has kind of a social stigma. Now the problem is that the community is at this level. The NACO program is from the ministry level. It is giving funding, it is giving free condoms. It has to percolate through that machinery and reach the user. Now the user is not aware of what the politicians or what the bureaucrats or the technocrats of the country or what the NACO program is doing. We cannot ask the ASHA workers to get into this phenomena. We cannot ask the Anganwadi workers. We cannot ask our health workers who will go. So it is kind of a difficult disease to tackle. For them, we made a special category of our grassroots level workers. These workers are called as the link workers. So only MCQ which can be asked to you is that what is this link worker? The link worker is going to link what to what? The link worker is going to link the community. Listen to the words very carefully. The link worker it's a new program. It was launched just 2016-17 it was started, and it is trying to scale up to the whole country. In the link worker scheme, we have launched the link workers who are going to link the community or the HIV people or the high-risk groups or the bridge population with the NACO program. So they will link the community with maybe the testing ICTC centers, they will link with the ART centers, or they will link with the health facilities. They are going to help in early diagnosing of HIV and disseminating the awareness about HIV. So that is what is the link worker. And of course, all the patients who are with HIV, they will be given free of cost ART drugs. Who's going to supply them? Who's going to monitor them? Who's going to report the cases or any adverse effect? It has to be someone. These are the link workers. So it was launched very recently. These are the link worker schemes. They work at what level? Please note they work at the community level. Very shortly, we are going to discuss a little bit more about the link workers, but for now, these are the strategies. It is one of the newer strategies that we have for HIV. So that's all about the strategies. Let us move to the next section for understanding of the NACO program. That is, what is the organization or the organogram. So you already know that at the center, there is a center. And below the center, we have the state, the district, the sub-district, the village level, and the community level. On one side, beta, I am going to talk about the laboratory system of the NACO program. On the other side, I am going to draw about the treatment services of the program. That is the main broad areas. So if you look at this organization from a single eye view, I'm trying to show you what is happening in the whole country. So it could be your rural areas, it could be your urban areas. We can talk about the communities or the villages. That is the main grassroots level thing. So at the grassroots level thing, just now we learned that at the lowest level, you have the link workers. The link workers are the most important people who are going to work for the NACO program. Then at the sub-district level, we have something called as the link ART centers. They are the link ART centers. Please note, it is not the ART center. ART centers in our government machinery, they are located at what level? The ART centers, please note, are located at the district level in our country for the NACO program. So every district is going to have the ART centers. ART is at what level? District level. So what is this link ART center going to link? Link ART center will link the link worker with the ART center. So it technically will do the monitoring. There is a medical officer available at the link ART centers. There are professional health workers, and then there are counselors which are available at the link ART centers. So there they will do the monitoring of the program, the treatment, any reporting of the adverse effect by the link workers. So they are actually going to have the surveillance. They will be the eyes. the link ART centers, they will be the functioning units. But ART centers will be the main monitoring unit at the district level. So this program runs its administration. Administration happens at the district level. As I have told you, in all the health programs, any program which is health related program will work at the district level. So ART centers are at district level. Above ART centers, you can have the state and the centers. Now in India, we have lot of medical colleges. The medical colleges will work as ART plus centers. ART plus centers, plus some of the medical colleges will also work as center of excellence. So that is what we have as the treatment system. What do you mean by the ART plus centers and what do you mean by the ART center? What is all this? Please note that the ART center is going to take care of at all the ART centers, we are going to receive the first line antiretroviral therapy. This is called as the FLAT. At the ART plus centers, and the Center of Excellence, in those cases, we are going to receive the alternate FLATs, the second line ART, the third line ART, raltegravir based, darunavir based, all the combinations. Please note that I'm not talking about the dolutegravir. The dolutegravir based is a first line ART. It is available at all the ART centers. So try understanding that the ART center is for the first line drugs. The second line drugs, the third line or the alternate regimes, everything will be taken care by some of the centers in the medical colleges. In the medical colleges, we have established the ART plus centers. So in some of the medical colleges, there will be ART plus centers. Some of the medical colleges will have the Center of Excellence, which works for research in HIV and AIDS. So this is how we are giving treatment. So the treatment management is done at the district level. The district is going to distribute to all the sub-district level. What do you mean by the sub-district level, beta? I think by now you must have understood this whole NACO program. Why? Because you must have learned the video where we talked about the health system in our country. At a sub-district level, which hospital is there? Please note I am talking of the CHC now. So at the village and communities, you might have the PHCs, the sub-centers, but the CHC is considered as a sub-district level, CHC or a block hospital. Block hospital is called as a sub-district level hospital. Please note that all the district level centers, they will be taking care of the ART. Above district, at the medical college level, at the state levels, we will have the ART plus centers. Now coming to the laboratory system. If we talk about the laboratory system, you already know that there was the mobile ICTC centers and the fixed ICTC centers. The mobile ICTC centers are available where? The mobile ICTC centers will be available. Mobile ICTC centers will be available at the village level, at the community level. They will be going to different villages. At the district and the sub-district level, we have the ICTC centers. This could be both the SA ICTC centers or we can have the FICTC centers. They could be both the standalone ICTC centers or we can have the fixed facility integrated ICTC centers that could be available at the district or the sub-district level. So what we have done is, let us say that you have a beautiful nursing home. So people from the NACO, they will come to you and say that, sir, you have a very good nursing home. Why don't you open a ICTC center? So if you open a ICTC center, the government will do all the funding. We will train your laboratory technician. We will provide you everything and almost anything. And that center will be called as a facility integrated center. So that is called as FICTC center, or there could be simple standalone centers. That is where the caseload is very, very high. So this is what is the organization of the NACO program. If you just look at the organization about the laboratories, we already talked that at the sub-district level, village level, and at the district levels, you will have the standalone and the facility integrated centers. At the community level, we will have the mobile ICTC centers. Talking about the care and support system, we already talked that the ART centers will be available at the district level hospitals. Then the link ART centers is below the district level hospitals. The link workers would be working at the community level. Coming to the last part of this NACO or the NACP program, what are the indicators? Beta, to understand the indicators, you need to understand three basic broad indicators, which are the main epidemiological indicators. The first indicator is the prevalence of HIV. in ANC females, the prevalence of HIV in the antenatal care females. Second indicator we need to do is the prevalence of HIV in high risk groups. What are the high risk groups? You already know: female sex workers, male having sex with male, the transgender group, and the intravenous drug abusers. Third is the indicator will also talk about the known or unknown hot spots. So these are the three important epidemiological indicators which are going to tell you about the HIV prevalence in our country. These are pretty important. Very soon I'm going to just categorize these indicators. But for now, just understand that please note, these are frequently asked MCQs. What are the indicators for the NACO program? Now, if they ask you that how to categorize these indicators, what do I mean by categorization? So now the government, what they had done is, the NACO people, they have done a district level categorization. District level categorization. That is, all the districts have been categorized in India. So we have district A, district B, level C and level D. At the first point, they are going to talk about the HIV prevalence in ANC females. If the HIV prevalence in ANC females is more than 1%, then job is done. That is called as a category A district. It is a very high risk area for HIV in our country. In case the HIV prevalence is less than 1, then it could be a category B, category C or a category D district. In these cases, now you go and judge for the level of transmission in the high risk groups. So HIV in high risk groups. HIV in the high risk groups. If it is more than 5%, then the job is done. This is called as a category B district. So what is a category B district? Which has HIV prevalence less than 1% in ANC and more than 5% in the high risk group. Next is, in case the high risk group is less than 5%, it could be a category C or category D. In third level, what do you look for? You look for any hot spots. You look for any hot spots. If the hot spots are known, if there are known hot spots, that means there was some congregation of the male migrants or something like that. That is called as category C. And if there are unknown or no known hot spots, that is called as category D district. This is what we have in India as the district level categorization. So now, just before we close off this session, a few points about which are the most recent advances which have happened over the last 2 or 3 years, just to enumerate them. The first is a talk about the vaccines. What are the vaccines which are available for HIV? We have a RAV vaccine. RAV vaccine stands for a recombinant adeno-associated vaccine. It is the same, the viral vectored vaccine using the adenovirus. So we have a recombinant adeno-associated vaccine. It is by the name of the Ankara vaccine. It is by the name of Ankara vaccine, which is being under trial. Alongside, you should also know there is a based on the P24, that is the antigen part. So based on the P24, there is a recombinant particle-based vaccine. And based on the recombinant particle-based vaccine, because we are talking about the P24, there's also another type of vaccine which is available, that is the GP120 core protein vaccine. It is one of the protein-based vaccine. So either you use an adenovirus to make the DNA or the RNA of the virus enter into the host cell, or we use the recombinant technique to include the particle P24 particle-based vaccine, or it is the core protein vaccine. These are all the vaccines which are currently under trial for HIV. Second is the launch of syringe distribution centers. What is this syringe distribution centers, beta? Just like what we had launched the female condoms, you remember that if there is a commercial sex worker earlier, like long 5-10 years back, we were giving male condoms. So we were giving male condom to a female commercial sex worker, asking her to ask the male client to wear a male condom. Are you getting it? So, but that female also has the right of protection of health. So that's the reason the government of India, the NACO program, they included the female condoms. So now we have the female condoms into place. On that same principle, we also have the syringe distribution centers, that people who want to take the intravenous drug abuse, they can do intravenous, because that is their own prerogative. So the government says that you do whatever you want, but you take syringe from us, at least don't share needles, because sharing needles will cause a higher chance of having HIV transmission. So that is about the syringe distribution centers. It is to give free syringe. Free syringes are available under the program to decrease the chance of intravenous drug abuse transmission. Third point you need to remember for your exam is what are the different type of surveillance which is available under the program. Please note that we already have discussed about this serosurveillance, right? We already have discussed about the sentinel type of surveillance. Serosurveillance is to find out the burden of TB. Sentinel surveillance is to find the missing cases. Apart from the sero and the sentinel surveillance, at the health worker level, we are also doing a AIDS case surveillance. That is to find out directly the opportunistic infection or people who are currently showing maybe some symptoms of HIV or AIDS. So that is AIDS case surveillance, and alongside we have also started a new novel technique of doing surveillance, that is the behavioral surveillance. See beta, what the concept behind behavioral surveillance is pretty simple, that after 10 years, maybe in 2030, who are the people who are going to get HIV? They will be those people who might who might be having a high risk sexual behavior right now, or they might be having drug abuse behavior, or they might be having high risk alcohol behavior, because these are the risk factors that why people land up into drug abuse, right? So technically, if we can catch these people, you might dent upon or you decrease the HIV cases in the country. Because it is not the problem of the sex workers, it's not the problem about the IV drug abusers. It's because if the HIV transmission happens in the country, the doctors also are at risk, the army men are also at risk, so they also have the right of health. So who's supposed to protect these people? It is the NACO program which is going to protect the people. So technically the program wants to decrease the HIV transmission in the country. So how to decrease the HIV transmission? They included a new technique called as behavioral surveillance. It is happening in many educational institutes. Using the Ministry of Education manpower system, and during their using their mechanism, we are doing behavioral surveillance. That is just, you can remember, another type of surveillance. Next is point number 4. What are the different projects, new projects which have been launched under the NACO program? This can again be a recent advance question for you. The new project, first you would like to remember, is Sunrise. Where does the sun rise in the world? Like, it of course rises from the east, so I have remembered it that way. Sunrise project was launched in the northeastern states. Why only in the northeastern states? Because you know that the highest burden, highest means the highest, it means the maximum. The highest burden of HIV is found in MNM. What is MNM? M stands for Meghalaya, N is Nagaland, M is Manipur. The highest HIV prevalence per unit population is found in northeastern states in Meghalaya, Nagaland and Manipur. And the problem of HIV over there is because of two things. One is unsafe sexual behavior, and the second point is about the drug abuse, intravenous drug abuse. So the Sunrise project, it is to decrease the intravenous drug abuse, or to provide them safer mechanisms, or to provide also them opioid alternatives. So now opioid alternatives are being given by the NACO program, free syringes are given. So everything is like focused to decrease the HIV transmission in the country. So decrease IVDA and to promote safe sexual practices. Similar looking program using the same modalities, because the strategies have to be same, right? You can't invent new strategies. So the similar looking program with the almost same strategies has been launched in the southern part of India. It has been given the name as Nirantar program, Nirantar project. These are small projects. It is in the southern part of India. It is in Andhra Pradesh, Telangana and Maharashtra with Karnataka. Why did I lay stress on Maharashtra? Because Maharashtra, do you know, it has the highest burden of HIV. What do I mean by burden? The maximum number of people living with HIV is in Maharashtra. Not because the HIV is a problem, it is because the people are so many. So the number of HIV is highest in Maharashtra state. Why? Because it is the largest state of our country with the maximum population. That is the reason PLHIV is highest in that area. And of course, because of many known hotspots also in Maharashtra. So Nirantar scheme is there in the southern part of our country. It is again to promote safer sexual practices, to decrease the intravenous drug abuse and all these things. So these are a couple of your projects. Another is point number 5, that the NACO program, every few years, they launch a HIV status report. The HIV status report is launched every few years, and this is called as Sankalk. Sankalk. This is the Sankalk booklet. So beta, if you can visit the website of NACO website, if you visit their website, you can download this booklet over there from there, and this booklet will give you all the updates in HIV. In fact, many of the updates that I already have talked in this video and the previous one, they are from the Sankalk 2021 update that we have from the Sankalk booklet. So that completes most of your topics from the NACO program about the targets, the strategies, the organization, and the monitoring indicators. Thank you so much for watching this video. See you in the next National Health Program.